Yeah, when I logged in, we were 23. Now I can see we've become 31, 30. Yeah, so I think we are good to go. I think you're usually that number. Anyway, we'll see as we give you your cut this week. How many of you will appear? Because physical, you're fewer. Okay, I understand about rooms. Should even become worse, you know. Even my rooms nowadays are taken. It's become very complicated, but we are working on it now that there's no graduation. At least in the next meeting, I'll raise it. So I know we have a pending class of the female genital tract. Um, we discussed with the class rep, Faith, and she said we do it on the 20th. Is that correct, Faith? Which is next week. I thought 20th was so far, but then I just noticed it's next week. I think that's the only time you have an available slot. Because I'd said I'm ready when you are ready. So I decided to just continue with the rest as it is, the brain, the CNS. Of course, if I got an earlier slot to do the female genital tract, I'll not mind. Just with a prior, like a day notice, I'll be able to organize myself. Yes, so we'll do the CNS. I'll do a bit of introduction and then we look at CNS. CNS, we will cover traumatic injuries. CNS is wide, and given that can cover everything, so how we have divided to cover for your group, we've divided that we'll look at the traumatic injuries, look at infections, then look at cerebrovascular disorders and the brain tumors. On the cerebrovascular, we'll see whether we will be able to cover a bit of hemorrhage that could either also come in there. Although some of it you can also have time to read on, like hematomas and those hemorrhagic things. You may be able to also be able to cover those. We will not be able to cover many other things that happen in the brain, including degenerative disorders, etc. So we are limited a bit to the most crucial parts for your group. So that's how we will cover the CNS. So I'll start with a small bit of CNS where we look at injuries, traumatic injuries. Let me get my slides on. Just a minute. Sorry, I'm just trying to see the ones for now. I have a mixed up of my notes. Just give me a second, because there's one where I have. Yeah, small issue with my notes. Just think I am doing my 5th year, which is incorrect. Yeah, so we'll do it. Yeah, I mixed up your notes. Oh my goodness, what have I done? Dramatic. This is it. Okay, can you see my screen now? Somebody? Today. Hello,
Yes,
and
yes.
some people have dropped out. I don't know where they've gone, but I'm recording, so I'll be able to figure out who was there throughout and who wasn't. Okay, so before we start, I like asking questions before we start. Before we start, my questions will be: have you ever had a patient with meningitis or a CNS disorder? Let's not go to meningitis, CNS, because we are in CNS, central nervous system. Any disorder? Julius,
Yes, meningitis.
meningitis. You've seen someone with meningitis, any CNS disorder, by the way. Timothy, I have two Timothys in this class. So Timothy A and Timothy B. So Timothy A is usually, both of them are K, yeah? Kipruto, I remember your face, your faces. So Timothy A, Timothy Kagevera, anything CNS?
Yes, we've been covering meningitis in clinical pharmacy, and we learned some bit about it, the inflammation of the meninges.
Okay. So you've done at least a bit of that. Hey, good. Any other disease, not necessarily meningitis and encephalitis, any CNS disorders. You can type, you can unmute. I know I'll call out your name. Washira Ann, hydrocephalus, very good faith. Washira Ann, any disease of the CNS, ugonjwa ya CNS. It could be congenital, it could be infectious, as we are discussing. It could be hydrocephalus. Hydrocephalus is both acquired and inherited. So faith has given us both. And imagine we are not covering hydrocephalus. You want notes later, you can ask me, I give you for that. But they're in your book. Polycarp, very nice. Brain abscess. And I know you meant abscess. It came out as abscess. I understand it's a typo. Very true. Infection sometimes can cause a brain abscess. You guys don't even know about tumors. You can get a brain tumor. You've never heard of a brain tumor? Astrocytoma. Okay, you may not know those names, but brain tumors are there. It's just like everywhere else. There's congenital malformation, spinal bifida. Nyinyi hamjaiona mtu akona spinal bifida. Ni hydrocephalus pekee. Can be just in the same way we say congenital, inflammation or infection, then a trauma, glioblastoma, Wanjiru, very nice. That's a brain tumor, very common. And in fact, when you get grade 4 glio, the very bad one, glioblastoma, very bad prognosis. Dr. Gideon will teach you those also. There are many. You see, there are many things: infections, tumors, trauma. People. You heard someone was hit through traffic accident. They got a subdural hematoma. Just a hematoma below the dura. So you can have a hematoma above the dura. So there are things that you know. So that's what we are discussing. We're now getting the details about it. Washira, I see now you're awake. You're writing something. We'll wait for you. And Timothy Kipruto did not say anything. Kipruto did not say anything. So next, of course, I'll ask Odinga and Njoki, Pauline. Yeah, because they've not said something. Okay, so you be ready. Gliomas. Okay, correct. So let's look at what I have for you today. This is CNS. Asa is lost now again. Okay, today I don't know what is happening. My cursor keeps getting lost. Okay, there we are. But I can't see my cursor. Can you people see my cursor?
No, it's not visible.
Yeah, I can't even also see it. And I wanted to also have photos for you. There are many things that are showing up. This now. There are too many things that are showing up. Let me remove all these things and bring back the what we should be seeing. I don't know, because my cursor is not there anymore. I can see where you are, but I can't move to the next slide. problem now. Okay. Give me 1 minute, I sort it out. I don't know what the problem is. Now you can see and you can hear me.
Yes.
Okay. So our learning objectives today is very short. It's just looking at you will review. I'll not go back to CNS anatomy and physiology. I think the whole neurolocomotor system we went back is too wide. We'll describe the traumatic injuries, and then we'll describe now the infections, mainly meningitis and encephalitis. Of course, the bulk of it is in meningitis, but we'll discuss a bit of viral, which occurs in encephalitis. Then that's it. Then the next teacher will look at cerebrovascular and tumors. We'll not be covering those other many things in this one. Now I can see my cursor. I can move to the next one. This is not. You can see. Okay, so we look at that. So under that, we look at general, the skull, the related soft tissues in the whole system for nervous, meningitis, the brain itself, the parenchyma. Look at the spine, and there's meninges which are also in the spine, in the nerve roots and the spinal cord, because sometimes you can also have injury to that. Like when you look at congenital malformations, which is not going to be in our covering. I don't think it's also coming up in the next. I don't think it's, we didn't cover it at your place. We picked what we think is really relevant for your group. So it's, but spinal disorders you will find, for example, even in like congenital. Okay, but it's good for you to go read, like spinal bifida, congenital malformations, then peripheral nervous system. That will only look at mainly anything infectious, but mostly traumatic. Just mention a bit of traumatic. So that's what we have for today. So we look at the pathology, just the way I've mentioned. So we usually have developmental anomalies. We have inflammation and infections, which we'll cover today. We may have, we usually have demyelinating disorders, like your MS, etc. Vascular disorders, which we'll cover, and then dementia, which falls under, infections may cause dementia like HIV. We may have trauma that may cause dementia. It can be a complication, but it's also a topic by itself. I think you do it a bit in your, I think there's something in pharmacy that you do is also psychiatric. So that will come up there. Then we look at the neoplasms. So for me, I'll just look at the trauma and infection. Okay, so we look at traumatic injuries. So of the nervous system. So this could be on the brain, could be on the spinal cord, could be on the peripheral nerves or autonomic nerves. Of note is that it causes a lot of disability. We've all noticed that injury can cause, paraplegia, like the lower limbs all the way down. You can't move. You can, paralysis. It could be hemiplegia, weakness of one side of the body, hemi. It could be quadri, where you injure at the cervical spine. I'll show you all those. And now downwards, you're paralyzed. So as I said, disability, okay? And also those long-term neurological impairments, even dementia is etc, especially even in the young adults. And of course, trauma can cause mortality, like road traffic accidents, either you as a pedestrian or you as a passenger, okay, in the vehicle. Okay, so that can happen. So the severity and the site of injury also affects the outcome. For example, if you have injury to the brain parenchyma, if it's in the frontal lobe, can be clinically silent, like you're not having neurological deficits. But if it's on the spinal cord, it can cause, paraplegia, all those disabling. And if it's involves the brain stem, the brain stem has all those important things, respiratory, cardiovascular, it can be fatal. So it depends again also on the site and how severe the disability will be. Okay, so for the sake of today, this class, I've divided the traumatic injuries into the central nervous system, where we look at the head injury, including parenchymal injury, the brain parenchymal injury, and then spinal cord injury in brief. Then peripheral nervous system in brief. That one, I think they're just 3 slides. Looking at, if you're injuring an actual nerve, or, you can also injure like the brachial plexus, brachial plexus on the upper limb, etc. Just briefly for today, for the class. Okay, so we'll start with just a photo to show you the one for the brain, because we'll start with the brain. We'll start central nervous system. We'll start with the brain. So for the brain here, we look at things that we can get as trauma. You can get a concussion, okay, which we'll discuss briefly. We can get a contusion. We can get a counter-coup, a coup and a counter-coup injury, or just injury, diffuse injury to the axons. You remember how your anatomy, So you have the axon, the oligodendrocytes, the myelination part, etc. So you may injure even the axon. So diffuse axonal injury, which we'll see. So we'll discuss this under traumatic injury, okay, for the brain parenchyma. So we start with that. And what that is, it's damage to the brain itself caused by external forces. And the commonest that we have seen is road traffic accidents. You see that a lot. Can also be because of falls. And as I said another time, that falls may be accidental, okay? Or it could be homicidal. Or, okay, if you're looking at death, for example, and I think that's how I'm confused. You people are confusing me with the 5th year group, because this I teach in 5th year. Okay, so could be someone has pushed you, like an assault, or you could have fallen accidentally. Okay, so those things can cause brain injury. Could be because of sports injury, could be industrial at work. Okay, they can cause that. So the types of injuries can either, what we get could be the primary impact effect, or the consequences of the primary injury. So we'll call that secondary injuries that occur later. But the ones immediate at the impact, you can have the concussion, can have the contusion, you may have a laceration, or you may have the diffuse axonal injury. That's immediate impact. Then later, because of that impact, it may cause, like when you have contusions, etc., they may cause cerebral edema, swelling of the brain, parenchyma, or lack of blood supply or oxygen supply to the part of the brain, hypoxia or ischemia. Because of brain swelling, you may have increased intracranial pressure and sometimes infections, because if there's trauma and there's, like even a fracture, etc., you may end up having an infection, depending on whether it's like an open fracture or closed fracture. All those things can occur. We'll talk about infections in a few. Then other things that may occur in traumatic brain injury are hemorrhages in the cranium. Okay, this can either be epidural hematoma, that's above the dura. Okay, these ones usually have like a lucid interval. This will be discussed in the next class, so I'll not discuss them in detail now, but we need to know they can occur. A hematoma above the dura, a hematoma below the dura, okay, or a hematoma within the subarachnoid space, okay, or inside the cerebrum. So we have intracerebral hemorrhage. That occurs a lot, like if you have aneurysms, like aneurysm that bursts, or sometimes just trauma that can cause intracerebral hemorrhage, which may be fatal. Okay. So most of this, we see them at autopsy, yeah? These hematomas, but you also see them in the surgical units because of trauma, like a subdural. Could have happened, like 6 weeks ago, a drunkard fell, he didn't realize. Then after 6 weeks, they start having those gradual deterioration in their whatevers. When they come in, we do a CT scan, we see the subdural. Okay, so this will be discussed in the subsequent lectures, the different hematomas, okay? But again, as I said, they can occur because of trauma too. And the types of trauma we have discussed, accidents, which is commonest. So clinical features, how will those patients present? They'll have loss of consciousness. Okay, they may have headaches, they may have vomiting. In fact, if you have increased intracranial pressure, you have projectile vomiting. Inaruka mbali, like when you vomit, the way you can just vomit on your clothes here, but this one, projectile, it's like a projectile, like when you're throwing something far, it's like that. Then they may be confused, they may have seizures, fits. Then when you examine their pupils, they, you put a light, then you will see they're not equal. They're not equal. Then they may have the focal neurological defects, okay? Like paralysis or hemiplegia, one-sided, we have a palsy, like a cranial nerve palsy, those are focal neurological effects. Then when you do their GCS, the Glasgow Coma Scale, do you guys know about the Glasgow Coma Scale? Timothy?
Yes, we learned about it in medical skills.
Ah, perfect. Yeah, so when you do, it's out of 15 and the many things you look at. So usually if you have trauma to the brain, then the scale is less than 15, okay? Then the investigations will do, as I said, but a CT scan of the brain is the gold standard. It will show you those things. It will show you that hematoma. It will show you those things, okay? So that's what we do, okay? Then, of course, MRI is more advanced than CT scan, of course, more expensive, and not everywhere. So, of course, that one will show you now more details, like if you have diffuse axonal injury, it will show you those things. And then, of course, you have to monitor the GCS. As I said, some things will be transient, so they can go back to normal. So the only way you can know is by looking at the GCS. Are we moving back to 15 out of 15? Okay. Then general, at a level of medical officer, they have to stabilize the usual ABC. I think even you guys do those things of ATLS, like first aid, but a higher doctor level, the ATLS. So ABC stabilization, if I refer gently, if the GCS is less than 15 and they're having seizures and focal deficits, then observe is just mild head injury, you see. And then if they need oxygen, hydration, you give that. This, I usually put general because Julius will always ask me on behalf of the class, what do you do? So I put general management there for you. But now let's go deeper into all these details. And I'm talking about concussions, contusions. What do we see? What do we see? Some of these I see at autopsy, but some of them you'll see at CT scan. Like patient is not dead. So we are seeing, especially in the trauma ward, so surgical ward, we see that a lot, okay? So we look at that in detail. As I said, it's injury to the brain itself, okay? The parenchyma of the brain, and we said the causes, road traffic accident, etc. The types, we say concussion, contusion, laceration. I'll mention that laceration, I see a bit of that also in, when someone is shot. Yeah, so sometimes they will shoot on the head. So you'll see your entry wound, like on the forehead, gunpoint, and then the exit somewhere on the occiput or thereabout. And then when you open the brain, you just see the way it's lacerated. It's torn, it's like torn. That's what you see, yeah? So yeah, those, for lacerations in the brain, I see at autopsy. Again, sorry to say that, but yeah. And by the way, I started teaching autopsy from February, myself, Dr. Obiero, and Gitinji. So sometimes when you're free and you're within the hospitals where we are, you can join the autopsy class and just come. I teach anyone who comes around. If I'm doing an autopsy and I'm with my students, you just join and you learn. I'm not the only one. Even the others do the same. Eh? So pathogenesis, how do we get these injuries? The concussion, etc. Again, as I said, the primary impact, and then there's the one after hours, like the direct damage to the neurons, the axons, to the blood vessel itself, which will cause bleeding, which is a hematoma. Can be a coup injury or counter-coup injury. I'll show you photos of how that is, okay? Then it could be shearing forces, which now just tear even your axons and everything. Even the movement, acceleration and deceleration may cause diffuse axonal injury. Eh? That one is really bad. Eh? Then secondary cases, I already mentioned, edema, ischemia or hypoxia, increased intracranial pressure, ICP, excitotoxicity, when you release neurotransmitters, and then inflammation and infection. Eh? So let's start with our first one, because I said could have concussion, contusion, laceration, or DAI. So we start with concussion. And what's a concussion? I was waiting for people to say about a concussion, the way we talk about it, throughout and all. And it can happen anywhere. Like there's this guy who is around, it was Speed. I don't know if you guys know about Speed, the streamer who caused havoc in Nairobi yesterday. Yeah, Faith, your people, Timothy.
Yes, I just Speed.
Yeah. Like the way he was moving in that vehicle and everything. I'm not saying, I'm just saying the movement and everything, and he's excited, and everyone is following. You're seeing guys even on a border just to follow and see the guy all over the place. And I'm thinking, in my head, I look and I'm like, yeah, it's exciting, but this funny movement of rushing and all that can be a bit dangerous. Yeah. But anyway, I got to know who the person is. I didn't know. And my son kept on disturbing, Mama, we have to go and see. I'm like, who is this? But I discovered in the whole estate, I was not the only one not knowing. Anyway, moving on. The reason I was mentioning this guy is because of the kind of movement I was seeing of him, and then the followers. You're not even taking precaution. You're just following. I mean, it's shocking. I still don't understand, but yeah. Let me just continue with the class. You could easily get these things I'm talking about. Concussion, like that. So concussion is just transient loss of neurological function. When we look grossly on the brain parenchyma, there's no damage, there's nothing. So they usually have this altered consciousness. Like you lose consciousness. Sometimes they can have a temporary respiratory arrest, like they're not breathing, and then you check their reflexes, they're gone, but they recover. They recover fully. It's complete. They may even have, not remember what happened. Amnesia of those events, of what happened. Pathogenesis, of course, the disruption that we see of the neurological activity, we don't know. It's unknown. The pathogenesis is unknown, how it occurs. But if I was to be given that gross brain, or even on CT scan, it's normal. We don't see anything. Microscopically, usually also is just normal. Mild axonal swelling may be seen, but many times it's just normal. And the outcome after this concussion, reversible. So it's like the brain was just shaken like this, and then back to normal. But during that shake, when they were shaking the brain, of course, the person lost consciousness, temporary, respiratory arrest, all those things. But there's no contusion, there's no bruise on the brain. There's no, you look at the brain, you think there's a bleed, there's nothing. It's just normal. That's a concussion. Okay? Which we see, okay? Then the other one is now a contusion, cerebral contusion. For a contusion, it is bruise. there's bruising of the brain, which there. Okay. Commonly, we see it on the frontal and the temporal lobes, the front and the sides, temporal. Grossly, we'll see hemorrhagic areas on the cortex, on the cortical surface, then swollen brain tissue, like a bit of sort of like edema. And then often we'll see it when you have the coup and the counter coup injuries, which I'll show you on a photo right now, and you can read about it. Microscopically, we may have some necrosis, neuronal necrosis, the hemorrhage that I've talked about, and the swelling, which is edema. And because of that, just that small injury, the body reacts. So there might be inflammatory cell infiltration, the cells coming to fight. Okay. Then with time, because it will just heal, it will heal with, like what we say, healing with fibrosis. So in the brain, we say healing with gliosis. Okay, the glia. So I said normals, you have to remember. Okay. So I show you photos of that, of the concussion. So you've been hit here, like the way you hit accidentally the wall. Okay, so this is it. So it's like the brain gets shaken, but it goes back to normal. You don't see any, you just lose consciousness at the moment and etc. But there's no actual injury on the brain parenchyma when we look at it. Okay, for the contusion, now there's like a bleed. Okay, so it will appear something like this, like at the point of impact, like here. Okay, yeah. So there's a normal brain, then there's accelerated deceleration injury, it hits like that. And sometimes with this, you get a coup and counter coup. So here, point of impact is a coup, then the opposite side will be the counter coup. The first was here, then the brain shake, the shaking of the brain, you can see my white arrows like this, and the other one backwards to the other side. Okay. So I show you this is where the first was. I show you another photo of the counter coup. So the injury, the impact is here. Then there's a shaking of the brain. So you'll also have the counter coup on this other side, the secondary impact on the other side. Yeah, so as I said, this will happen, the contusions etc. in the counter coup and the coup and the counter coup sides. So these are the sites I'm showing. Okay, like even the second here, and this looks more beautiful. So impact is here, and then counter coup is here. Okay. So we go to the third one, which is so laceration is a tearing of the brain tissue. And I give you a very typical example that I see in practice is when you have like a bullet, someone is shot, like even close range, and there are different ways we describe how far the shooting was. So there's close, there's mid, there's contact, there are things we see that we describe. And so we're able to describe an entry wound and an exit wound and the trajectory, there are all those things. So in this one, the lacerations, I see a lot of that. Okay, you can see even in fractures, but I see a lot of it when you have gunshot. So the brain is just torn. Okay, so there's regular torn areas of the brain with associated hemorrhage, often due to severe trauma or skull fracture. Okay, yeah, so that's what we see. Okay, microscopy, disruption of the parenchyma, hemorrhage, necrosis, and areas of gliosis. We see that. Then that's for laceration. Sorry, I didn't have a picture for gunshots. I'll have to go to my library for forensic. I didn't have that one. Then diffuse axonal injury, which is the other one, is widespread axonal damage due to rotational or those accelerated, decelerated forces, like the photo I showed earlier. Okay, in the middle, this one in the middle, accelerate, hit very fast and move. Okay, or in road traffic accidents, when the guy brakes so fast, the car was just next. So those accelerated, decelerated forces. Grossly, what we see is will appear normal, or you see some small hemorrhages, especially when you dissect the brain and you're looking at your corpus callosum or at the brainstem. We see those small hemorrhages. We see that. Usually when we do autopsy, we dissect the brain, every part of the organ. Yeah. So microscopically, if you're to now take that part of the brain with the small hemorrhages and look at it, you'll see what we call retraction balls. But the best thing we usually do is use a special stain, immunohistochemistry, so that we're able to pick those axonal swellings. They're not as obvious. I think the only thing in the brain that is obvious when you see this is swelling and like gliosis on histology. So those are the different injuries that we see. Immediate injuries, the immediate injuries or impact injuries. The ones which are secondary, we'll see them in many other places. Ischemia, we'll see them in cerebrovascular accidents, edema, increased intracranial pressure. So I put more on the class today on the impact, the direct impact, and not the secondary consequences, because those will come along in all the other classes. Okay, so I didn't discuss more. Intracranial pressure will be discussed in the subsequent classes. Okay, so that's what I've looked at. So clinical features, how will these patients present? If you're having the traumatic injury, either the diffuse axonal injury, etc., they'll have loss of consciousness, they'll have the headache, the vomiting, confusion, they may have amnesia, forget what was there, they may have fits or seizures, neurological defects, and the Glasgow coma scale will be reduced. And then when it's very severe, they'll go into a coma, especially when you have very severe injuries causing diffuse axonal injury. It's very severe, they may go into a coma. Okay? Yeah, so we see that a lot even in RTAs, road traffic accidents. Diagnosis, as I said, of course, there's history. You clerk the patient, you find out, they tell you there's history of trauma. Sometimes it's something they remember. Then neurological exam, which is a must do, because that's where you pick. If they're having all these neurological deficits, the Glasgow coma scale is by examination. Okay. Then imaging, as I said earlier, the best choice for acute trauma is a CT scan of the brain. Okay. You may do a MRI, but CT scan it will show you those things. It will show you the edema, it will show you hemorrhage, it will show you those contusions. Yeah. So usually the best. And then, of course, you may do an MRI, but CT scan is good enough. CT scan is good enough. It shows you all those things that you're looking for. It's good enough. Okay. Then management, general management, as I said, as always, you do your ABC. You do your ABC, airway, breathing, and circulation. Make sure they are okay. Immobilize the spine, of course, because you don't want to cause more injuries. Oxygen if they need, fluids, etc. Then specific measures, refer if the GCS is very low, where to a place where they can manage. If they have repeated vomiting, then there's a lot of increased intracranial pressure going on. If they're having seizures, all those you refer. If they're in pain, if they're having, epilepsy or epileptic seizures, then with time, because that's even a complication, you have to give anti-epileptics. Okay, so make sure you avoid secondary injury, like make sure they have enough oxygenation. If they're hypotensive, give them IV fluids. Don't cause more harm than what the trauma did. Just preserve the patient. Okay, special measures. Okay, I don't go into deeper details of management, so you allow me to leave it at that. Then we just look at our complications. That one of those is, of course, increased intracranial pressure because of the swelling of the brain. They may have herniation. Now, I mentioned that when you have increased intracranial pressure or brain edema, remember the skull is like a wall made of stone. It's that hard thing like that. So the brain is inside that wall. So it is now swollen. So there's no way of, relieving the swelling. So what does it do? It looks for the places with the weakness, where it can pass through. That is called herniation. So it looks for a place where it can herniate. Okay. So there are different sites where it can herniate in the brain. So that's in the skull. So that's what happens. And the worst is when it herniates through the foramen of magnum, because at that level, it's a brainstem which will herniate and go downwards. And the brainstem has your cardiovascular, respiratory, all those things. And that's how the patient will end up like dying. Okay? When you have that form of herniation. In fact, I should give you an assignment. When you go today, you look at the different sites that herniation can occur in the brain, because of increased intracranial pressure. It's very, very important, the parts for herniation. You look at, if it's a fracture, it can herniate outwards. But if there's no fracture at all, foramen magnum, you can go to the different sites. I'm almost saying the answers, but because I want to give you as an assignment, let me not say. So go look at herniation. And the worst one, as I said, is the one that can go brainstem and cause death. but the other side, it's not just brainstem, I mean foramen magnum. Then they may get, as a complication, epilepsy, post-traumatic. They may have cognitive impairment, personality changes. Of course, maybe the frontal lobe has been affected, etc., and those chronic headaches. So then complications that can occur because of this traumatic injury. So it's good to remember that, okay? So that's for the brain, okay? So we'll need to move now next to the spinal cord. So the brain has a lot, eh? The brain has a lot. We see a lot of brain injury, yeah? Even at autopsy, yeah? So we move to the spinal cord. And for the spinal cord, causes again, highest on the list is road traffic accidents. Falls also come there, fall from a height, fall not just from a height, even fall, like bathroom falls. I find spinal injuries a lot with a fall in the bathroom. And I keep insisting that make sure the bathrooms are clean and the architecture guys make sure that they're done properly, yeah? Because sometimes you'll go to a bathroom where the tiles are soapy and slippery and you can easily slide and fall. So those bathroom injuries, I've seen them being associated with injury to the spinal cord, eh? So falls, just put them as falls, okay? Then violence, of course, assaults, etc., and sports injuries, okay? So the level and effects, at level at which the injury is occurring on the spinal cord, like if it's at the cervical region, especially above C, is it C4? C1, C2, C3, C1, C2, and Atlas, up there, C3, C4. At around C3, C4, you will get quadriplegia. What does quadriplegia mean? 4. So downwards, all the way from the neck downwards, you're paralyzed, okay? So you're having all the 4 limbs and, downwards, you're paralyzed, quadriplegia. Then if it's at the level of some of the T's, thoracic injury, you'll have paraplegia, the lower limbs, okay? Then lumbar injury, you'll have bowel and bladder incontinence, dysfunction, okay? So very important. Also, when you're examining now, you need to know at the level, when you're doing your CT scans, etc., so that you see why the patient is presenting, how the patient is presenting. Okay, so pathophysiology again is primary mechanical damage to the site, maybe fractures, cervical fracture. Then secondary effects, as I said, this happen later, like the edema, the ischemia, inflammation, etc. Clinical features, of course, they'll start with weaknesses. So they may have like a hemiplegia or a paraplegia weakness. Then paralysis, now it becomes completely, they can't move. Then loss of sensation in those areas, okay? Loss of bladder, as I said, when it's lumbar injury. Then spinal cord shock, spinal shock, they may get that with flaccid paralysis, okay? Yeah, check on all this. This must have been discussed even in your physiology, Yeah. So I'm just mentioning them, spinal cord, okay? Investigations again, you do an X-ray. An X-ray is good enough. Sometimes on the spine, you're able to see if there is a fracture on the spinal vertebra. CT scan, as I said, is very good. MRI will be good to see the damage to the spinal cord. The spinal cord is tissue. So MRI is very good with tissues, in vessels, etc. Okay, so management again at this level, immobilize the spine, the ABC resuscitation, and then refer early. And if there are any complications, you have to give treatment. If they get urinary tract infections, treat that, because the bladder problem. If they have, make sure they don't get pressure. So, lying down on the bed all the time. So there's something they do in nursing skills. Turn the body, the patient's body every 4 hours, turn so they don't get, at the point of impact of bone to the mattress, etc., they don't get pressure, so wounds, they don't get wounds. That's what we call them. Okay, so that's spinal cord. Now we move to peripheral nerves. Again, as I said, that one I only have a slide on that. Peripheral nerves, causes of injury to that, it could be a cut. This could be either assault or accidental cuts. Could be fractures, which then injured the nerve. Okay. Compression effects like the carpal tunnel syndrome on your wrist. That one can be really bad. And like I had carpal tunnel syndrome but mine was not traumatic. It was, I'll say what my gynae said, because of the pregnancy, I had a lot of edema, etc., which was compressing. So, and it is a very bad thing. Carpal tunnel is a bad thing. You know, the way we just read it in books, until you experience the disease is when you know how bad it can be. It was horrible. It got to a point I was like, you just terminate this pregnancy. I want to be normal, you know, because there's no way you get carpal tunnel, and the reason is because of the edema around there or something. That's what they kept on saying. Anyway, so peripheral nerve stretch injuries also. Okay, you know, like these guys who are hiking, who are in the gym, and all those, you know, could be those stretches that they, you know, there's how you're supposed to do it. You'll be taught by your physio, or sometimes the orthopedic surgeons and orthopedic physiotherapists. They tell you how to do it so that you don't injure your nerves or make them worse. Then, so the types of peripheral nerve injuries, there's a classification they talk about. I'm not sending you to go read in details or anything, but they'll have those ones which is like neuropraxia, where there is temporary block of the neuron, but you get full recovery after you've gotten the injury. Or you can have the axons, so they call that axonotomesis. So the axon is the one which is damaged, but again, you get recovery. You may get full recovery. It may be possible after injury of the axon. Or neurotomesis, which is complete severance, completely. So even recovery is like poor, not very possible. Let's put it that way. So there's that classification again. It's a good to know. Nice to know. Put it that way. Nice to know. So I'll not harass you about it, but I needed a slide on peripheral nerve injury. So clinical features again: weakness of specific muscles that are supplied by that nerve. Sensory loss, again, according to the nerve distribution. You actually get numbness. You can't do anything. I remember for me, it was usually on the, they tell you on the dominant. So it was on my dominant hand, the right hand, because I'm I'm right-handed. So I could not even feel. I would get numbness and pain, you know, paresthesia and all those things on the right side. Try to hold ice cubes, you know, like take away that bad pain and, you know, sensory loss and everything. You know, throughout, I'll go to the fridge, I get ice cubes just to hold. They put plaster of Paris. They put all the things. Yeah, so you get those things, those feelings. Loss of reflexes, you know, you with your patella hammer, nothing. Okay. So examples, you can have the radial nerve palsy, where you get a wrist drop. You may have a facial nerve palsy, where you look at the face and there's loss of symmetry on the face. They'll have like the mouth is moving to one side. They may drool on that one side, drooling from the mouth. Then you'll see like a crease on the face on one side. That's how they look like when they have a facial nerve palsy. Then ulnar nerve injury. The ulnar nerve is the one which is medial on the elbow side. They will have claw hand. It looks like a claw. Okay. So when you have those injuries. So treatment again, you have to treat the underlying cause. Lots of physiotherapy is done and analgesia, and then refer to the surgeons to see what else they can do. Again, I leave it at that. I'll not go into details of that management further. But those are the traumatic injuries that we would get on the nervous system. So complications of nervous system trauma, intracranial injuries, sorry, I put them as two. The increase in intracranial pressure, as we said, epilepsy, chronic pain, cognitive paralysis, and even depression. This is very important. My last bullet, the depression and psychological sequelae. It's important because you know what people are calling mental issues and all that. Depression can occur because of you are well and now here this has occurred, you know, like say you have quadriplegia. So there are MDTs for management of these patients. Okay. Multiple, you know, like multidisciplinary treatment. You have your physiotherapy, you have your psychologist, very important to counsel these patients. Yeah. So I'm done with that part of traumatic. Questions for traumatic?
Yes, thanks, Dr. Kaggia. Can you please
Go ahead,
the brain gunshots?
Yes.
Yes, I've seen. I've had these patients who have lodged bullets in the brain, and
Mm-hmm.
the neurosurgeon say that those bullets cannot be will cause
They
more
cause more harm.
harm than when they remain there. And even right now, we have remember the Gen Z revolution last year. It's a
Mm.
gentleman at Kenyatta who still has a bullet in the brain, and that one really disturbs me. What exactly can that? Which part of the brain can necessitate bullets not be removed?
No, Julius, very nice question. And it's not just the brain, eh? There are different parts of the body when you see they are close to an important place, like even spinal. I've seen others around some areas of the hip to the spinal. You don't want to touch because it will cause more trauma. So correct. I'm not specify and say it's in the frontal lobe or temporal lobe, eh? But what usually happens, the bullet is not big. Sometimes it's a shrapnel. It's a small part of the bullet. And the thing is, for you to go and do surgical removal, like go and get into the brain and go to that area and remove, you'll cause more damage to the surrounding area, maybe cause more edema, etc., and make the patient even worse than they were. So we usually just observe. So it's not a specific site. I say it's because it's frontal lobe to mwachane, apana. It's not a specific site. But we do, like the CT scans, MRI, and look at the site. And usually they will sit as a team and discuss. If we approached using this, there are different approaches of going to remove. They see what are the side effects of doing it. If we went there and by mistake, things happen. This happens, like a vessel is injured, we're unable to ligate, etc., or you cause more laceration on that brain tissue. And yet the patient looks okay. Because I have a few who are working normally. Okay, my own whatever was shot by gangsters. And this is how many years later? 20, maybe 24 years later, the bullet is still intact. I mean, the shrapnels, you can see when you do an x-ray, you will see it, but walks normally, okay, there's just a small, effect on the walk, but if we go in to remove it will cause more damage. So we just leave it. So it is something that we usually do as medics, yes. So, but your question of which site, there's no specific site because it depends on the approaches that can be used to go and remove. Yeah, but of course there are sites that are very dangerous, like brainstem, because that's why you have many vital parts, systems. Yeah, but correct, many people, yeah, will be having. Yeah, sometimes just like some inflammation, you should be around there. So you keep observing. You observe patients, so you can say annually. First times will be like quarterly, then you go annually, then you go biannually, like that. Yeah.
Okay, and then so the body you comes and then now adjusts and just accepts the bullet as part of its system because remember foreign aspects in the body cause reactive or immuno-related stuff.
As I said, you may have like
Certain
there is an
medications.
inflammation, like a chronic inflammation around there and surrounding that area. The macrophages work, so it's not more
Yes.
harm, like where you need to give. It's a chronic thing, like a chronic inflammation that wraps
Yes.
around it, like a capsule around it.
Okay.
Then you just stay with it like that.
Ah.
So it will not cause
Ah.
immunological changes.
Okay.
Those ones happen
Thank you.
immediately. Then after that, there's nothing.
Okay. Thank you so much. I appreciate.
Yeah. So it's not only brain. There can be other sites. Like you go to thorax, important organs, you see. Okay.
Yes, you are right because I
The
think
Gen Z person is still there. You said the Gen Z.
yes, it's still at Kenyatta.
Even now. But that's,
Even now.
I see you.
No, I've got
Or
to go
normal.
surgical ward. They are just surgical ward. They are just observing.
Is he responsive?
Yeah, it is responsive,
Mm.
but some of his limbs are not functioning well. So he's
Uh,
just there for observation. He's not able to walk.
mm.
Yeah, but he can talk. He can eat.
Oh. Oh, but at least if he's able to eat and whatever, maybe, yeah. As I said, there are those things we look into. Yeah, I understand. Okay, Yeah, as I said again, you see, like now for him, well, he's there with us. It's only that now the disability. Remember, my first slide was the disability.
Yes.
Yeah, maybe that's just the only issue now for him, for example.
Asante.
Yeah. Trauma is wide. By the way, you've seen how I have summarized it in like 20 slides. I didn't even talk about details of, like the hematomas when we get them, the people who survive like subdural hematomas people would have. They're prominent guys, even politicians who had subdural hematomas, and I remember like when I was a medical officer, there's a time we actually even did a barhole of an epidurals hematoma. It's above the dura. So you do what we call a barhole. You create a hole on the skull, then you drain the hematoma. We would do it even in the district hospitals. For me, I went to school when we were doing district hospitals, not county. So yeah, so those are there. They are there. Okay, anything else before I move to, I take you to infections? Okay, so then let me move to infections now. Again, my cursor is, I'm putting another slide. I don't want to start with the encephalitis. I want to start with meningitis, what you see more. So you give me 1 second. My cursor is keeping. Now you can see my screen.
Yes.
Yes,
Yes,
now
yes.
infections. We finished. Remember, we said we are doing traumatic. Then we look at infections of the meninges and then of the brain parenchyma, which is encephalitis. So that's why I moved from encephalitis to first do brain and parenchyma. And my first question would be, how do you think infections get to the brain or to the nervous system? How do you think infections get there? Chepto, Belinda, anybody. Belinda, how do you think infections get there? Tundo, Brimstone, how do you think infections get there?
It can be through the blood.
Through the blood, okay, but coming from where now in the blood? But correct, you're very right. I agree with you. Anybody? Belinda has written through the blood. You can unmute too, okay, whichever is faster. Drusilla? Oh, people are writing surgery. Timothy has put trauma, correct. Keep writing. Different ways that, this is how I look at it. If I were you, I'll look at which infections do I know that are there in the brain. Then you guys have done microbe, so could be bacterial, could be viral. It's multiple users typing. So I give the multiple users 1 minute. Just 1 minute. One minute almost over. Wait for polycarp. Mm-hmm. One minute is over. So it's just Tracy and Timothy saying something. Okay, I'll catch up with them as I look at what people have typed. So we start with Belinda, the blood hematogenous. She mentioned. Rita says during surgery, very true. Kipruto, trauma, very true. Njoki, from adjacent infections like sinusitis. Very well done. Very true. It's a common thing that occurs, Njoki. Then my phase, bacteriema, very true. Bacteria in the body and just moves like either through blood, for example. Mia is blood. Yes, nitrogenic. Very well done. Okay, it's not trephine, it is lumbar puncture. Many times lumbar puncture, when you want to get CNS fluid, you do a lumbar puncture, but correct, iatrogenic. We could be the ones doing that, correct? Hematogenous, like when you have Neisseria, true, that's polycarp. Autoimmune, I think, Wanjiro, you want to say somebody is immunosuppressed, because autoimmune is not an infection, okay? I think you want to say immunosuppressed patients are more, they get opportunistic infections. And then local extension, correct, Timothy, just like sinusitis, or if you had a fracture, then it just moves in there. Tracy, we were waiting for Tracy to finish through the nerves, correct, okay? So I see you at least you have an idea of the infections and the roots. So I put for you here, they are just what you said: blood, hematogenous spread, direct impact, like what people have said after trauma, okay, with introduction of foreign materials, etc. Iatrogenic, the one that was just mentioned, it's not trephine. Trephine is on bone marrow. Trephine biopsies on bone marrow. That's why I said it's lumbar puncture. Okay, when you want to remove cerebrospinal fluid, you do a lumbar puncture at the lumbar spine, usually L4, thereabout. You bend the body of the person, of the patient, then you put your needle there. So it's called a lumbar puncture. So iatrogenic, if you don't do it as an aseptic technique, you're not careful. Extension, which has been said by like 3 people. Sinusitis, that was the first one you were given, correct? Either mastoid or frontal sinusitis. From an infected tooth, it may also climb up there. From a surgical site, it was also mentioned, either in the cranium or in the spine, where you have osteomyelitis, which then gets into the system, or bone erosion, okay, which may go all the way to the CNS, or even congenital malformations. Okay, so there's some congenital malformations which are not occult, which are open. So you have the meninges being exposed, and so they get infection. Okay, if you look at your spinal bifida, there are different types of spinal bifida, and you will find these which I'm mentioning, which can predispose to infection in the CNS. Okay. Then peripheral nerve, which is the last one Tracy said here. So you can also have entry through the peripheral nerves. Good examples are your rabies and your herpes zoster. I'll mention in passing those things. I had said I won't do it, but I may mention 2 or 3 slides with photos. I'll just bring up a different slide show just to show you, so that at least you have an idea. Okay, I'll just go past what we were supposed to cover. So those are the infections. Okay, how the infections get into the CNS. Okay, so we'll start with, and the infections can either be meningitis or encephalitis. So we start with meningitis. Okay, as Timothy told us, I think you did that when you're looking at one of the units. He said meningitis was taught and he said it is inflammatory process of the leptomeninges. Definition of meningitis. Okay, just as he said, we can have meningoencephalitis, where now this inflammation or infection of the leptomeninges and CSF spreads to the brain parenchyma. Encephalitis is the brain parenchyma. Okay, so you may have those 2 together. So many times meningitis is usually because of infections. However, we can have chemical meningitis, which is non-bacterial. It's an irritant that has gone there, chemicals, okay? Not an infection by itself, not microorganism. It's not as common as these other ones, but I have seen it. As somebody mentioned about autoimmune, I would mention that sometimes you get aseptic meningitis in the, like what I have seen in the past, I've seen a patient with aseptic meningitis who had SLE, autoimmune disorder, okay? But not as an infection. So yes, we could pick that as an autoimmune 1-0, okay, as chemical meningitis, okay? Infections, we will classify them broadly as acute pyogenic, or many times it's bacterial, pyogenic, pass on the chemical that I mentioned, like, which I've seen in SLE, autoimmune disorders. Then chronic. Now, these chronic disorders like TB, fungal, cryptococcus, okay, yeah, syphilis, the spirochetes, etc. Of course, the commonest is acute pyogenic. Eh? So on the basis of the characteristics of the inflammatory exudate that we see on the CSF, when you do a lumbar puncture, we're able to see the evolution of the disease and know which one it is. We can actually isolate the microorganism in the CSF, okay? Yeah, so it becomes easy for us, okay? Yeah, so we start with the acute pyogenic, or I've done them as summaries. So acute pyogenic or bacterial meningitis. So this is caused by bacteria, and I'll talk about the different microorganisms common at different age groups. So the microorganisms as etiology, we have E. coli and group B strep are common in neonates. A neonate is a baby born from day 0 to day 28, the first 1 month, they're called neonates. So the commonest microorganisms that cause meningitis are E. coli and group B streptococci for these neonates. Then for the young adults and the infants is now that 1 year, and the young children, those toddlers, etc., the commonest is your H influenza. Then adolescents and young adults, the ones who stay in dormitories, in schools, in, those whatever crowded places, the commonest is your Neisseria meningitis. It even has, like if you read more about Neisseria meningitis, you will see that even it has like a time when epidemics occur. Yeah? So just read more about it. And you look at the belt. There's a belt on the map when it will occur. Again, it's good to know that. Okay, so again, it's common in adolescents and young adults. We see it even in schools, those dormitories, in call them cells or jail, like restricted areas. Then for the elderly, we see strep pneumo. And then even older people, we see Listeria monocytogenes, okay, Listeria, and the older ones. Now that you've done microbiology, I just mentioned them like that, then you review also your other notes for microbio. So those are the commonest microorganisms and the different age groups that we'll see. So the clinical picture, once the patient has been infected with this, what do we see? One, they will have fever, of course, because it's an infection. They'll have headaches, vomiting. They may have photophobia because of light. They're irritable. They have confusion. Then they have neck stiffness, rigid neck. Because of the meninges around the neck, when you try to, it's so painful. So they remain rigid so that they can, you reduce the pain. So they have neck stiffness. Then you do the Brudzinski sign and the Canning sign, they're usually positive. I'll send you to check a YouTube of how those signs are done. It's easier now because it's a virtual. I'm not able to demonstrate. Just do a check the way you look at speed, the streamer moving around. Just put video and see how you examine for meningitis. You check the Canning sign, and I probably have a picture, but if you did a video, it will be easy to see. Okay. So that's how they will present. But now, how do you make the diagnosis? You'll say, of course, physically, this is an impression of meningitis. For diagnosis, we usually do a lumbar puncture. So as I mentioned, you go at the lumbar region on the back, you put your needle, then you get the CSF. Now that procedure is very important because when we are doing it, we check the CSF when it's coming out. Is it coming out under pressure? And what do I mean? Itaruka. When you put the needle, then poof, like when you open a tap where you had put your finger, then it's like you have just released the pressure and so it just jumps out. So that's very important. You need to check, is the CSF coming out with pressure? Because when it's coming out with pressure, many times it means a pyogenic infection, meningitis, increased pressure in the CSF. Then now when it comes out, you look at the color. Is it cloudy? Is it pus-like? Is it purulent? Is it cloudy? Is it purulent? Or is it clear? Because that will mean something. So for the bacterial meningitis, they will come out under pressure, itaruka mbali. Then it will be cloudy, like purulent, like pus. Then when you go to the lab now and you're doing the analysis, because we usually we do chemical analysis, and then we do bacterial analysis, and you do cytology analysis. There are 3 things we do for all fluids. So chemical analysis on the chemistry bench, you want to check at the levels of proteins and the level of glucose in that CSF. So if you have bacterial meningitis, the protein will be elevated and the glucose will be reduced, okay? And then now when you put that on a slide, cytological analysis, you'll have numerous neutrophils. It's an acute bacterial. So you'll have many neutrophils, okay? And then you are also able to isolate the microorganism, which you can do, your gram staining, then it tells you it's gram positive or negative, then you do a culture. And you're able to pick the actual microorganism. So we have to do all those, okay? So that's what we do on the CSF. So those are the characteristics you find in acute meningitis, bacterial meningitis or pyogenic meningitis, the one from bacteria. And I've mentioned the different groups of bacteria and age group. So complications you will get is that you'll have phlebitis, inflammation of the vessel. You may have thrombosis, a thrombi being formed because of that inflammation, etc., or hemorrhage. Then because of blockage of the vessels, you can have infarction of the underlying brain. Then because of healing, remember meninges, you've treated the disease and it might heal with fibrosis, healing with fibrosis. And because of that scar or fibrosis, if it occurs at the level where the cerebral spinal fluid is reabsorbed back, where you have the granulations, arachnoid granulations, where the cerebral spinal fluid is taken back, and the fibrosis blocks that area, you can have now hydrocephalus. Remember when Faith mentioned hydrocephalus, I said hydrocephalus can be congenital or acquired. So this is a form of acquired hydrocephalus because of the fibrosis. After an infection, you've healed with fibrosis. So you're not able to reabsorb the CSF. So it accumulates and becomes small, which is called hydrocephalus. Then you may have a brain abscess forming, okay, or ventriculitis, inflammation of the lateral or the third ventricle or the fourth ventricle. That's rare, but it may occur, okay? Of note with this meningitis is that you can have what we call Waterhouse-Friderichsen syndrome, which is with the adrenal gland, okay? When you have the meningococcal or pneumococcal meningitis, which becomes septicemic, like bacteremia in the whole blood, they can have hemorrhagic infarction on the adrenal gland, okay? And the patient has those cutaneous hemorrhagic petechiae on the body. So you link all those things together. You look at the adrenal and it's because of the meningitis, then it has caused infarction in the gland. It's a whole topic. So I just mentioned, as I said, if we go to all details, we'll never finish the class. So just note, I have put the most important things on this slide that you need to know. So that can occur in the adrenal gland, okay? Yes. So that's for acute bacterial meningitis. And as I said, I'll show you a photo of Cunning's, but I'd rather you do a video and see for yourself. This is just a way of remembering. His knee extension is painful. Okay, so the patient lies like this. You can see the way they are. Then you try to extend the knee here. Then they'll feel the pain. Okay, so this is how they lie supine. Then you flex from the hip like this. Then you try now. You see, you're trying to move this to extend. See, it's flexed. That's the knee. Now this guy is trying to straighten it. That's extending it. They feel the pain. Okay. They cannot be able to do that. Then this is the Brudzinski sign. Neck rigidity is like this. Okay. When you're trying to do passive flexion of the neck, it causes a lot of flexion of both legs and thighs. Okay. It's just a mnemonic for remembering. Again, just check it out. A video will show you easily. And it becomes a common routine thing when you're examining for these patients when you're doing a clinical exam. So I show you, because we said purulent, pass, okay, pass in bacterial. These are some of the things that we see. Unfortunately, this is at autopsy. This patient, of course, died of meningitis. And as you can see from the photo in the middle, you're just seeing a layer of whitish thing. This is pus covering the brain. It's just pus. You can see even on the last one, you're just seeing pus. Yeah. And if you take this and look at it under the microscope, you just see the numerous neutrophils that I said. Remember, in a living patient, you will see this in the CSF. This one now is at autopsy that I'm showing gross. So you have pus or exudate on the leptomeninges over the surface of the brain. Okay, as you can see here. Yeah. This is at the base of the brain. You can see the whole of it here. This is your sac of Willis. This is all of it here. This is your cerebellum, which is usually a very beautiful organ. Then microscopy, you'll see numerous neutrophils, as you see here, which will fill the entire subarachnoid space. Okay. Yeah. And you can do a gram stain of this pus and see the different microorganisms. Okay, so that's for acute bacterial. You remember the way we said pyogenic? Then we said aseptic. I'll talk about viral in a few, but now we go to TB. Okay, acute, chronic bacterial TB. Okay, so TB causative agent, of course, will be your Mycobacterium tuberculosis. Remember, TB will have a chronic way. So in acute meningitis, pyogenic, they'll have a short duration of symptoms. In chronic meningitis, whether it's TB or fungal, they'll have a longer duration of the symptoms, okay? So they will have headache, but this one they'll say more than 2 weeks, more than 3 weeks, they've been having headache, they have malaise, they may have confusion, and even the vomiting. But there's chronicity in the presentation, okay? Again, for the CSF findings, when you do a lumbar puncture, in TB, you see more of mononuclear cells. So you'll see your lymphocytes and like seeing the polymorphonuclear cells, okay? They're there, but they're not as numerous as you see in acute pyogenic, okay? Then the protein level is elevated here and glucose is either reduced or normal when you analyze. And may result in a well-circumscribed mass, which we call a tuberculoma. I'll show you a photo of that. And again, when it becomes a mass in the brain, it causes something called space-occupying lesion and may cause increased intracranial pressure. Again, in the next class, you'll talk about space-occupying lesions, especially tumors. But a tuberculoma can also cause that when it's well circumscribed as a group, as you know, as a lesion, a mass. That's the word. Okay. And then this chronic TB is caused is associated is a very good cause of arachnoid fibrosis. As I said, the CSF, the way it circulates, you guys have done physiology and anatomy. So when it's removed, from your lateral ventricles, etc., and moves, it is then reabsorbed back at the arachnoid. So if you have fibrosis at that arachnoid, very common with TB, if you have fibrosis there, then you don't reabsorb the CSF. So it accumulates and you get hydrocephalus, right, for the chronic TB. So this is your tuberculoma. As I said, it's a mass. So you may have a mass like this. Okay, this is a tuberculoma, okay, in the brain. Again, this is autopsy. Sorry to show you that. Then you may have the pus again like this in TB. Again, a tuberculoma down here, a space-occupying lesion. Of course, your CT scan will say there's a space-occupying lesion. So you want to go in and find out what the CSF, you can even do gene expert. It will show you TB. Okay, then you treat this. The TB microorganisms will treat even the CNS TB. So it's that's why I say TB in a TIBA. So I always want with TB, let's treat it because patient goes back to normal. Okay, yeah. So that's for your tuberculoma. I show you when we take histology of these. Again, it's a chronic granulomatous inflammation, as you see here. So you have your caseous necrosis here. Then you have your non-caseating epithelial granuloma. So you have your lymphocytes, your epithelial cells. They will be surrounding here like this. Okay, this is for the non-caseating. So down here, there's no necrosis, caseous necrosis. You see this part looks like it has cells, but this one looks like ghost cells. This is caseous necrosis. Okay, you can have both alternating like that. Okay, so this lymphocytes, the calf that I'm talking about, and plasma cells is what you'll see. These are your lymphocytes. These are your Langerhans cells. Remember, this is the best I can show you. It looks like a horse. The nuclei is around a level like this, like the legs of a horse, like this. So this is the Langerhans cells. Same here, histology showing the same thing. Your granulomatous inflammation, caseous necrosis. Then your nice giant cells, the Langerhans type. That's what we see in this brain. This is a CT scan. So CT scan will actually show you this. They tell you ring enhancing lesion. There's a way they describe as radiology. It's very beautiful. And they know how if it's tumor will look like, when it's benign will look like. So they tell us all this. Then you go in and we remove that lesion if you're able to, or you treat. If you do tests and it shows it's TB, you just treat. The patient will be okay. We'll go back to normal for TB. Okay. You okay till there? You're still on now chronic. So we've done TB on chronic. We look at syphilis. This one I only have 3 slides. Syphilis is more covered in your microbiology than in my CNS infection. So again, it's a tertiary syphilis that will occur, causing the brain or CNS infection. And it's going to be in about 10% of the individuals who are not treated for syphilis. The major things we will see in the meninges for syphilis are meningovascular neurosyphilis. That's what we call it. So it comes in 2 types, the paretic neurosyphilis and the tabes dorsalis. Okay. So for the paretic, you have the Treponema pallidum invading the brain. Okay. So what happens when you have that? Because I said it's chronic, it's a tertiary stage. You'll have progressive loss of mental and physical functions in that patient with very ridiculous mood alterations. You know, like if you guys, I'm sure you also rotate in Mathari and all that because of the drugs that you give. Eh? So these people are delusioned. Eh? They are delusioned. They have grandeur. You know, the way they own the world. You know, if you go to the psychiatric ward, you know the way those guys are. So they get into all that. Eh? Then they get into severe dementia. But now the pallidum now gets into the actual brain parenchyma and the meninges. So we call it meningovascular neurosyphilis. Okay. Then there's the tabes dorsalis. This one is root. So in the dorsal roots, okay, so you will have sensory loss, and then you'll have impaired joint position sense and ataxia, mostly locomotor ataxia, you know, movement, problem with movement. Okay. Again, this is best demonstrated when you do a neurological exam. So they'll have loss of pain sensation. When you do neurological exam on our patients, usually have like a pin where you prick the patient and you ask them whether they can feel, or you check their reaction many times. When you prick, you look at their reaction, you ask, you look. So these ones will have loss of pain sensation. And because of that, it's like a diabetic. When they get infection and all those things, they don't feel because you don't feel the pain. So you might even get traumatic injury and you didn't feel. So they'll lead to skin and joint damage, what you call the Charcot's joints, other sensory disturbances, like, you know, paresthesia or lightning pains that they get, and then they don't have any tendon reflexes, especially the deep tendon reflexes. Again, these are demonstrated in a neurolocomotor exam on a patient. Yeah, but that's what happens with syphilis, and I show you those. This is just a table to show you a guess of how long this infection can take to come up. This you can get it in your even microbiome. I think they mentioned this, of course, is just an approximate time interval that asymptomatic anytime, you know, the first time when they're symptomatic, they have those changes, primary, you know, genital area. Then now up to 2 years, they may get headache, meningismus, vomiting, elevated proteins, and lymphocytes. Then at the meningovascular, the one we're talking about, 7 years later, is when you're seeing the neurological deficits, you know, including even locomotor problems, etc., dementia, okay? Then tabes dorsalis is way many years later. Sensory loss, They have neuropathic pain. Then they have that Argyll Robertson pupil. Just Google, you'll see how it looks. You'll see it. It's there. Then general paresis, weakness, 10 to 25 years, including dementia, psychosis, flaccid paralysis. Then optic atrophy is lower, uveitis, on the uvea and the conjunctivitis, and even inflammation of the sclera. So this is just a time range that this syphilis. We don't have it a lot because we easily test for it and treat. Okay, we test and treat. So I haven't seen a patient with this things. Okay, so tertiary syphilis, you see like if you look at these folds, it's like they've been eaten up. Okay, the connective tissue is like it has been eaten up. If you look at this side, it is there. This other side is not there. Yeah? So they have what we call eating up. The folds are wide open up. We see like that in the tertiary stage. These are the Charcot joints that I was telling you about. They have loss of sensation. They have locomotor ataxia because of this. They have these problems. Okay. Again, syphilis was more covered in your microbiome than I am covering here. So go back to your microbe notes because I'm told you already covered it in second year. I mean in third year early microbiology. So there's a lot. Usually we give more details at this level of microbiology. We give all this at that level, okay? And patient presentations. So that's syphilis. At the end is when I'll talk about the other chronic one, which is slides, okay? I'll give the fungal. So we've looked at this. Now we do the viral meningitis. We've seen pyogenic, bacterial. We've seen chronic TB and syphilis. I'll talk about crypto as my last slide, but we look at viral now, meningitis. Then we'll go to encephalitis. Then we finish. Okay. Again, viruses, the common viruses that we will get. I forgot to ask people to tell me which viruses you think are common, but I'll give you. So again, it's more of a disease of children and young adults. Of importance is that it's self-limiting. At a point or two, many times with recovery, like full recovery as a rule. This viral. So it's something that happens a lot. Sometimes we might not even pick it. Most common, MCC stands for most common, the most common causes, okay, are the enteroviruses. Your ecovirus, your Coxsackie virus, your polioviruses, those are the most common. For the viral meningitis, we will see in viral encephalitis, your herpes is more common. But anyway, let's first look at meningitis. The least common cause is your arboviruses, your HIV, your herpes 1 and 2. Again, by the way, it's both. And mumps, CMV and mumps. Those are least common. But again, they can cause the meningitis. Clinical pathologically, what we see, the patient has a fever, headache, irritation of the meninges. They can have altered consciousness. When you do your LP, your lumbar puncture, here, viral, the CSF is clear. It's not turbid, it's not cloudy, it's clear. And it's not under pressure, okay? There's a mild or moderate pressure, increase in pressure. It's not like the bacteria. The bacteria in a RUCA, those are things I've done, so I know. This is just mild to moderate elevation of the pressure. Then protein is elevated, but the sugar is normal. Then here, remember it's viral, so you get more of lymphocytes, mononuclear cells. And then when you do your gram stain, etc., there are no bacteria. You don't see any of those. Okay, remember viruses, you test them differently, so you will not see anything on that. Leptomeninges, when you do like histo, you'll just see a mild to moderate infiltration by lymphocytes. Again, we never get to this part of removing the brain to do histology. Okay, so that's why I've put it down there. The thing we do is lumbar puncture. Okay, and now use clinical presentation. So that's what we see with viral meningitis. Then, as not so common, this I've just generalized it. Okay, that's why I only have one slide. Then for the brain abscess, which we also mentioned in our chat box, The most common microorganisms that cause it is your strep and your staph. Okay. Now, of note, there are factors that predispose you to get a brain abscess. Okay, and we'll see a brain abscess in the photos which I'll be showing you next. So some of the predisposing factors are acute bacterial endocarditis. Now we've already done this cardiovascular system, so we've covered endocarditis, and you can see those vegetations, etc., can be carried in blood and deposited in the brain and cause brain abscess. Again, another predisposing fact is when you have right to left shunting of blood, like when you have cyanotic congenital heart diseases. Okay, we've done congenital heart diseases, so at least you know those things. Or when you have chronic pulmonary suppurations, you know where there's pus, infections with pus in the lung, or just direct spread. You have otitis media, you know the chronic otitis media that keeps removing pus. Chronic otitis media, you may have mastoiditis, inflammation of the mastoid, chronic inflammation of the mastoid behind the ear, the mastoid there, or sinusitis. Those can lead to abscess formation. For the abscess, the presentation is slightly different. Of course, they may have the headaches and all that. However, because it's a space-occupying lesion a lot, you know, like the tuberculoma, as I show you here on this photo, this is a brain abscess here. You see where my cursor is? This is pus. And remember, an abscess sort of has like a capsule covering it. And you can see here, like the capsule, the cover, and here's another one, smaller one, like that. Okay, here's your abscess nicely like that. You go open, you see the pus, okay, and then you'll see. So because of that, they sort of present with neurological deficits, like on one side, depending on where the abscess is. So the opposite side, you may have like hemiplegia, weakness, etc. Okay, then they may have increased intracranial pressure features, of course, because the space-occupying lesion is increasing pressure around the brain. Then the CSF, raised CSF protein and cell counts. Again, more even with, because it's more bacterial, you'll have a lot of neutrophils elevated, but the glucose is normal, okay? Morphology, if you get the abscess, because sometimes you can, you know, they can decide to go and remove the abscess, you will see the capsule, as I mentioned, then the suppuration, the pus, okay? And then the normal tissue surrounding the abscess, you'll see gliosis, okay? Inflammation of the glia, have herniation, because the brain, they herniate. Then the abscess, the capsule may rupture. And if it ruptures, it can cause meningitis now. It can go and cause ventriculitis, you know, the ventricles. Yeah. Prognosis with surgery and antibiotics, mortality is less than 10%. You heal and go back to normal. You heal. Have I seen a patient with brain abscess? Yes. When I was an MO, an intern, I remember we used to see. Now I am hardly in the ward, so I don't see that a lot. But yes, yeah, I was there. So this the photo. So the abscesses are discrete lesions, as you can see here, with central liquefactive. Remember, it's a brain, so it is going to be liquefactive necrosis, surrounded by, you know, swelling around there and fibrosis. The gliosis I was talking about. Microscopic, this is it, okay? And neovascularization, you can see the many cells. It's just inflammation throughout here. Here there's like a vessel here, so we see neovascularization, necrosis, etc. That's what we see for a brain abscess. Again, as I said, if you treat, you can do surgery and give antibiotics, the patient heals, you know, less than 10% mortality. So it's not a bad thing. If you pick it early, again, I say for all disorders, early diagnosis. And that's why I keep on saying, and I think it's good that your class keeps insisting, and you ask, you know, just general management or what to do. If I have a patient with this, you know, for me, just telling you morphology and complications and leaving it like that, without telling you that if we did surgery and antibiotics to make a change, I may not tell you which antibiotic, you know, or the procedure for the surgery, but just mentioning, if you got a patient with that, then you know where to refer, and early, you know, because if you're in a health center, they can't do that. If you send to the level 4, we are able to manage those things. Okay? Yeah, we are able to manage those things. So early diagnosis, very important. Now we go to encephalitis. Go to encephalitis. Before we go there, any questions still where we are? Because you're now moving to the last part. We pause for questions as I breathe in and out also. Okay, no questions. I don't see anyone typing. Okay, we move to encephalitis. Give me 1 second. I will show you photos and nice things on my encephalitis like this one, but I want to give you a brief intro of general of everything. So I'll change the slide in 1 second and give you the other slide. So I stop sharing this particular one. I'm trying to look at the chat box. I don't see much. Okay, so then we can look at encephalitis. Just a brief intro. Then I've decided to, you see, like the way I've talked about like rabies here, etc. So I'll show you a few, maybe 2 or 3 more slides of, like rabies on top of this. I've chosen just 2 or 3, okay, which I'll show you. So this is general, like what I was supposed to teach. Then I'll go further and just mention 2 of rabies. I think I'll do rabies, CMV, and something else, okay? So encephalitis, again, this is inflammation of the brain parenchyma. I repeat, when we're doing meningitis, as we were told by Timothy, it's the leptomeninges and the CSF in subarachnoid space. Now we're going to the brain parenchyma itself. We call it encephalitis, okay? Most common causative agent is viruses, okay? And again, they'll cause a neurological dysfunction or deficit, okay? So as I said, most common infections and it's viruses, okay? Bacteria will cause meningitis more. Okay, so viruses. And you see viruses were causing very minimal viral meningitis. But now encephalitis, there's a lot of those viruses. So the commonest of them all is herpes simplex type 1. Okay. Yeah, especially the sporadic one, which can be fatal. Then you have varicose zoster virus, chickenpox, the herpes group. Then we have rabies, we have measles, we have mumps, we have HIV1, okay, where we are. Then we have your like arboviruses. Again, I won't discuss all of them. We just see. Then you can have an encephalitis, which is non-infectious, like what we were told by, was it Tracy? The autoimmune encephalitis, just like in meningitis, okay? And then post-infectious, okay? Immune-mediated, a few of viral, because that's where we are. So pathogenesis, remember we started by saying, how do the infections get to the CNS? So most of them for the viruses will be respiratory tracts from bites like your rabies or through hematogenous, okay? And they're able to cross the blood-brain barrier, okay? These viruses, okay? Then when they get there, they'll cause neuronal injury, okay? And of course, because of that injury, the body reacts by an inflammatory response. Okay, more of mononuclear, you'll see more of lymphocytes. Okay, so when it gets there, when it causes the neuronal injury and the inflammatory response, what do we see? It will cause neuronal necrosis because of the injury. Okay, then it can cause increased intracranial pressure, as we saw earlier. Then dysfunction of affected brain region. Okay, Like the way herpes simplex likes to be on the temporal side, so we'll have dysfunction of the temporal lobes. Again, I'll show you even photos of that. I'm just giving general now. Okay, so morphology, what we see, the brain because of edema will be swollen. And this is how we talk about the brain being swollen. Okay, I'll say like when you see on autopsy or what you're supposed to see. So there's flattening of the gyra and the narrowing of the sulci. You know, those furrows there, that's the sulci. So they get narrowed. And then the gyra, instead of having, you know, like, it gets flattened. Like if you, the best way I'll tell you, because now I'm not able to demonstrate, is you make a fist wherever you are today after the class. Then you try to push on a wall, a stone wall. Try to push your fist, the side of your fist where the fingers are on the wall. Then you'll see how it gets so flattened. That's what we see on the brain when you have edema. It's like that. So the wall, the stone wall will be the skull, you know, the bone in the brain. And so the brain which is swollen is trying to push against it. And because the skull is intact, or the stone wall that you're putting your fist is intact, it just gets flattened. So that's the flattening of the gyra and the narrowing of the sulci. So I'll ask you to demonstrate to yourselves like that. Okay. You'll see congestion, then you may see focal hemorrhages, especially on the temporal lobe if you have herpes simplex infection morphologically. Microscopy, main thing that we see with viral is around the blood vessels, perivascular, we see lymphocytic infiltrates. All these encephalitis, most of them, that's what we see. Lymphocytic around the vessel, perivascular lymphocytic infiltrates. Others like HIV, we may see microglial nodules. I'll show you those pictures. And then we can see destruction or, you know, phagia, like eating. You just see they're not there. The neurons are not there. They're getting destroyed. So we call that neurophagia, you know, like eating up of the neurons. Then inclusion bodies, very good for diagnosis, because those are the ones that tell you which virus it is. You know, the way it's very difficult to cultivate or, you know, get viruses unless, yeah, you know, like the way you see bacteria easily, it's difficult for viruses. So we look at different morphologies to help us know which virus it is. So we have inclusions in intranuclear inclusions like in herpes simplex. For rabies, we see something called Negri bodies. Again, at the end, I'll show you each of those. Okay. Clinical presentation, typical features is fever, headache, altered sensation, okay. Fever, as we said, headache, altered mental, you know, like confusion, drowsiness. They may even get into a coma. They may have fits or seizures. Personality or behavioral changes, you know, like depending on which lobe has been affected. Memory impairment, they just forget. Aphasia, you know, talking, you know, just focal weaknesses on one side. The next stiffness may be present, but less, like it's not a prominent thing like we see in meningitis. So that's why I've even put it there. I almost removed it because the main key clue for encephalitis is fever, altered. By the way, this is more of encephalitis because you don't even see those neck stiffness. You do Cunning's, it's negative. You know all that. So it's more of the fever, the altered consciousness, and seizures. Okay. Generally for the encephalitis. But now you need to find out which virus it is. Okay. So diagnosis, of course, the clinical suspicion. As I said, the key, if you see someone with fever, they're confused and they have seizures, think encephalitis. So you can do a lumbar puncture, you will see it's not under pressure as those other ones like bacterial. Then you'll see a lymphocytosis, very many lymphocytes, a raised protein and a normal glucose, okay? For confirming, you can do PCR, okay, of the CSF to see which virus, you know. You can do an MRI of the brain, which will show you which lobe has been involved, and it helps you. I'll show you a photo of where the virus is like in the brain. So like HSV or herpes simplex likes the temporal lobes. So MRI can show you that. Then of course you do EEG, you know, the other things for activity of the brain. CT brain to exclude mass lesion, space occupying lesion before you do an LP. Okay? Yeah. But MRI would be quite helpful here. Okay. So general management, general for all of them. Urgent referral, of course, if you see a patient with that and you're in a situation where you can't manage, you do your normal ABC, airway, breathing, and circulation, stabilize that, and refer. Okay, while they'll be taken, you can good treatment, like if you do antivirals, like acyclovir, it's very good for encephalitis. Okay, you can give that, before, because lab test might take long before you get results. So you can start the patient on acyclovir. Okay, then you give, of course, drugs for fever, analgesics. If they have seizures, you give antiepileptics. Then if they have increased intracranial pressure, again, you manage it. You give a mannitol ETC to manage intracranial pressure increased. Supportive treatment, again, you also give. Okay, general. Okay, which complications can we get with encephalitis? This is general. Again, cognitive impairment, amnesia, memory loss, epilepsy, personality changes depending on which lobe is affected. Okay, of course, death, if untreated. Like, for example, with herpes simplex, which also has a very good, if you give early antiretroviral, antiviral, they get, better early. But if you don't treat, it can cause death. So prognosis depends on the cause. Again, early treatment. So for the herpes simplex, it has the highest mortality if it's not treated, but improves very fast with early acyclovir. So as I said in the previous one, if you put on treatment even as you await results, you're helping the patient. That empirical treatment, it will help. Okay, it will help your patient. So that's general. The general picture I wanted to give. And see, I've mentioned many viruses. So I'd want to just go into details of like 3 or 4 the viruses, show you photos, and mention more about them, because I think it's good for you to know. Okay. Yeah, I sometimes think general is too much. I know the problem is that your lesson becomes longer, but allow me to do that so that at least we have an idea of this general encephalitis. Okay. So I'll stop presenting this particular slide for general and show you pictures of the other one. So I go to details of viral encephalitis. I want to see whether you can see my screen. Yeah, has anyone seen a patient with viral encephalitis or encephalitis? Oh, you just mentioned meningitis. Might be a bit new. Again, as I said, it's the brain parenchyma which is getting infected. And as I said, lymphocyte, mononuclear cell infiltrate. Talked about the microglial nodules like in HIV and the neurophagia. And then I said it's easy to pick some of them because they have inclusion bodies, which I want to show you now. That's the reason I put this here. Then the presentation the one I wanted to mention here is congenital malformations that may occur, like in the patients get torches, infection during pregnancy, the torches that we talk about, your CMV, your rubella, etc. They may cause also encephalitis, okay, intrauterine, okay, yeah. That's one of the slides. But now I go to this photo that I wanted to show you. And I wanted to tell you, like sometimes you'll see what the virus is like in the brain. So we start here at the bottom. This is more on the anterior horn cells and the bulbar and motor nuclear. More we see the polio viruses here. Then here, as you can see, on the cerebral cortex, and a bit of the cortex in the cerebellum down here, as you can see here, this dark red usually have more of the CJP, the prion disease. I'll send you to read that one. I'll not give you details of it, but you have more of those affecting the prion disease. Then we come up here. You can have what we call CML, CML, I'll talk about it in one slide, is progressive multifocal leukoencephalopathy, CML. They are a lot in immunosuppressed patients. It likes the cerebral white matter here around this region like this. Then you have panencephalitis, which will occur in the cerebrum, as you can see here. Here is your herpes there. Then you have others, we don't see them here. I've never seen the von Economo, which likes the midbrain and the hypothalamus. Okay, over here. Then you have your rabies. Your rabies loves the cerebellum and the brainstem. This lilac, okay, pink, peach appearance. That's why they like. So that's the encephalitis, you know, where they prefer the microorganisms. So we start with your herpes, which, as you've seen here, likes the temporal lobe. I'm just adding more details to what we did in introduction. Mostly the herpes type 1, okay, most common cause, especially in the US, and it's seen in the young children and young adults. It causes hemorrhagic and necrotizing encephalitis. As I said, the site is the temporal lobes. What we see, the HSV1, the labialis, will stay in the Gasserian ganglion in patients who get the labial herpes. Again, go back to your virology to read pathogenesis of these viruses and where they're still like a latent stage. Okay, so for HIV, for labialis HSV, it's in the Gasserian ganglion. Okay, then it will involve the temporal lobes as it moves through the intraaxial spread. From that site, it goes through the axial. It moves now to the brain, and especially the temporal lobes. So it's only about 10% that have history of recurrent labialis that will get this encephalitis. What we see on microscopy, if we take tissue from the temporal lobe, we'll see what we call Kaggia type A intranuclear inclusions. Just saying inclusions inside the nucleus. Yeah, so that's what we'll see on histology, and I'll show you a photo of that. These patients will have alterations in mood, they'll have behavioral changes and memory, okay? If you're involving the frontal and temporal lobe, that's what causes these changes in the patients or presentation. For the HSV2, the genitalis one, usually causes more of generalized encephalitis, not just the temporal lobes, it's generalized. And it's more in the 50% of neonates born by vaginal delivery because they'll pick it from the mother during the vaginal delivery. Okay, so you remember about torches. This is a baseline for this lesson. So I want to show you what we are calling the Kaggia type A inclusions. So here you have your cell. Then this inside the cell, in the nucleus, this is the intranuclear inclusion, which you call the Kaggia type A. Another one here like that, you can see inside this nucleus. Another one here inside this nucleus. This is a whole cell, then this is the nucleus. So you're having an inclusion. So when we take that and we do a microscopy on the histology, that's what we see. So it points to us that this was HSV type 1. Okay. These are the photos I wanted to show. We move to the next one, CMV. CMV again infects the nervous system in fetuses. Again, torches, the infections that you can get, intrauterine, torches, the CMV, okay? And also in immunosuppressed patients, you can have this. So the outcome of this infection in the uterus, when the fetus is in utero, is that you'll have around the ventricles, your lateral ventricles, for example, you have periventricular necrosis, which produces severe brain destruction. So the brain becomes small. It's followed later by microcephaly. Like a brain is made smaller, okay? Like you saw patients who got Zika virus infection, the way they were coming up with a microencephaly, that's the same thing with CMV, okay, when the child is born, okay? So CMV likes localizing around the paraventricular subepidermal regions of the brain where it causes the necrosis, hemorrhagic necrosis, okay? Again, CMV is common opportunistic viral infection in individuals with HIV/AIDS, okay? Remember I said you can have it in the mother-to-child transmission, fetus, or immunosuppressed, especially HIV/AIDS. We'll see that. Okay. Now we go to rabies, which is the other one. Again, you saw rabies loves the cerebellum and the, where did I put the photo? Here. The cerebellum and the brainstem here and the cerebellum here. That's where the rabies likes. Again, it's a viral thing. So it will cause severe encephalitis. How we get it is by a bite from a rabid animal, dogs which are not vaccinated against the rabies. And there are very many animals. I just use the dog because those are the ones we are having as pets in our homes. So the virus enters the CNS by ascending along the peripheral nerves from where the bite was, okay? So the incubation period for this one, it depends on the site where the bite is and the travel to the brain. So it can take a few months. I don't know, they have a photo to show that. Yeah, it's like the bite is here, then for you to get to the brain, like that. So that's what I mean. So incubation period depends on the distance between the wound and the brain, okay? So it can take some months. So the disease will have non-specific symptoms like malaise, headache in the early stages. But as the infection advances, the patient now starts having extraordinary CNS excitation, like neurotransmitters are released. Then, even a small touch, it's painful, they're really highly or extraordinarily excited. And then sometimes you'll have a violent motor response, someone attached to you, the way you behave backwards. Then with time, they even get convulsions, okay? And one of the things that happens with people also with rabies is they can have a contracture of the pharynx, the pharyngeal musculature, okay? Which may create an aversion to swallowing. So you don't want to swallow, they're having like a contracture, so they don't want to swallow even water, so they have a hydrophobia, okay? Then periods of alternating mania and stupor progresses to coma and then death with respiratory failure. So they become very manic, like the dog barks and all those things. So they become manic like that. Then they go to a stage of like they're dead, stupor. They're not moving, they're just there. And with time, they even progress to coma and then they die. And many times they die of respiratory failure. Okay. So this is just a photo to show you the bite and how it moves. So infection at the bite, then virus multiplies locally in the muscles, the myocytes there, which may take weeks or months. Okay, then it binds to the nicotinic acetylcholine receptors at the peripheral nerve to the CNS, as you can see. Now here it's reaching, then root ganglia. Okay, so infection of the brain neurons, very blood, saliva. Okay. Yeah, so that's what happens. Okay, that's for your rabies. Okay. So for us, when we take a tissue to see, because I said we are able to tell because we see what we call Negri bodies. Okay, so these ones are in the cytoplasm. So this is a cell like this. So we see intracytoplasmic inclusion, but now there's an inclusion in the cytoplasm. This one is what we call the Negri body. Again, now this is real. This is brain tissue, as you can see. And then this is a cell like this, the glial cells. This is the nucleus. Then in the cytoplasm, you're seeing these eosinophilic pinkish bodies. These are the Negri bodies we see in rabies. Again, I show you rabies. So this is the brain. Of course, this is autopsy. So we'll see the perivascular, remember I said perivascular monocytic inflammation. So these are blood vessels, and you have lots of lymphocytes around the blood vessel, like this, like this, like this. Then you go to high power here, you see in the glial cell, like this is the nucleus, but in the cytoplasm, you see the eosinophilic Negri body, like this. Okay, so it's this, like this cell is this one, like this cell, like this. You're seeing in the brain parenchyma. Then this thing here, which is pinkish, is this one. Okay, this is high power of this. That's the first one I showed you at at the beginning, what viruses will do. Okay, yeah. So this is just rabies. We go to polio. Polio, I don't say much because we do a lot of polio in your micro B. So I'll just mention and say how you can get it. Again, polio is fecal-oral. So when it gets into the stomach or the GIT, it causes a mild gastroenteritis. Then it climbs up and goes to the meninges, and then paralysis, and then even paralysis of the respiratory muscle, which can cause death. So go back to your virology for polio. There's a lot in polio. So the virus usually goes now to the anterior horn motor neurons and sometimes the cranial nerve ones, the nucleus of the cranial nerves, and then the lower motor neuron paralysis, the way you see patients presenting. For us, histologically, we'll see the earlier. For it, we also see chromatolysis, like breaking down of the glial, and then the eating up of the neurons. Okay. Then late response, we see loss of the motor neurons and healing with fibrosis, gliosis in the brain. Again, you know about the vaccines that you can give and the stories of polio. Polio will take me 1 hour to discuss. So I leave it at that. I send you to review your microbiovirology notes because polio, yeah, usually take it like an hour. It's a lot. HIV, I put like 3 slides for HIV infection causing encephalitis. I talk about HIV-1 because that's what we have here more in our country. Actually, even for diagnosis, we use more of HIV-1. If I suspect someone has a HIV-2, I have to send it to South Africa. I think that hasn't changed. Okay. So HIV-1 can cause aseptic meningitis. Okay. Seen in about 10% of patients during 1 to 2 weeks after seroconversion. Okay. And you could isolate the virus in CSF at that time. Okay. But encephalitis is more than meningitis. So we talk about encephalitis. And this one occurs late and presents with dementia. Remember that complex, the dementia complex that they talk about in HIV. So they may have apathy, motor abnormalities, ataxia, locomotor. Sometimes they may end up even having blood and boil incontinence. When we look at the brain in these patients, they usually have atrophy, mild cerebral atrophy. Like you do a CT scan and you can see that, involving subcortical gray and white matter. Then when you do, like us for histology, we'll see what we call the microglial nodules. Usually these have multinucleated giant cells. Then there's demyelination of the neurons and gliosis around that region. I'll show you a photo. We can have, other than encephalitis and meningitis, we can also have vacuolar myelopathy when it affects now the spine and mainly the posterior and lateral columns, okay, because of demyelination. Okay, so the patient will have paraparesis, okay, weakness on all the limbs, okay, and then walking, they have an ataxic walk because of that, okay. So a bit of how this HIV-1 gets in, it enters the CNS through the macrophages and monocytes. They have CD4 markers which interact with the viral protein envelope, the protein on the envelope. Then on the microglia and the astrocytes, they also have CD4 markers and they become infected and destroyed by the virus. Then fission of the macrophages produces the multinucleated glial nodules that I was talking about, which are the characteristic things that we see with the AIDS dementia. Nowadays, they call it HAND. Yeah, we see that. So the cytokines, viral products are produced with, all the things that may cause the damage to the oligodendrocytes. Remember, your oligodendrocytes are the ones that cause myelination. Okay, the myelin, laying down of the myelin. So if you destroy them, you don't have myelination of the neuron. So you'll have demyelination. Okay, yeah, and that is when you start seeing those neurological deficits. Okay, then of importance is the HIV causes immunosuppression. And so we'll have now opportunistic infections. You'll have your toxoplasmosis, your fungal cryptococcus, CMV, as we mentioned earlier, your PML, your herpes, all those, TB, all those. So HIV comes with many things. And tumors. Oh, I haven't mentioned these are HIV, especially EBV-mediated tumor, lymphoma. HIV. I haven't mentioned it here. Oh, okay. I think it's one of my slides. Yeah. Yes, it's here on my slide. I was wondering why I haven't mentioned it. Yeah, so HIV will cause these many things. I talk a lot about type 1 because that's what we have. So the HIV encephalopathy that I talked about, cognitive problems, meningitis, the faciolar myelopathy because of the columns being affected with the demyelination, peripheral neuropathies, all these polymyositis that can be associated with HIV. The opportunistic infections, which are a million, as you can see, there are very many. And then the neoplasms. The primary CNS lymphoma, it has a tie a bit even with EBV, but yes, primary CNS lymphoma, very important. Then metastatic systemic lymphomas, you may have that. And then Kaposis, we've seen that. Of importance is the CNS lymphoma. I'll about these ones first, but yes, they're there. Okay, so HIV. Yeah. I don't know whether there's anything else I wanted to say about HIV. It's wide, so most of it you will have seen it in your virology. Yeah, virology will tell you a lot about HIV. Okay, yeah, a lot of it is in your virology for these ones that I'm talking about. Okay, we'll see that. And then I just wanted to show you the brain. When you say this is a brain tissue, when you're talking about HIV and infection, this is the area. When you see the microglial nodule, this area like this, you can see the many nuclei. It looks like a multinucleated germ cell, like this one here. There are many inside there. There's another one here. All these are inside, and this one like that. So these are microglial nodules. Once we see this, it gives you that AIDS dementia complex. Yeah. See this, and we talk about that. So I'm about to finish. I think I have two more on PML. Remember I showed you the picture of PML and why it likes affecting, and it's more of immunosuppressed people here. There's a PML. Yeah. I mentioned it because quite a bit, anyway, things changed from the time I finished school, but we will see some patients with that when I was in undergraduate med school, as an intern and as an MO. Now, as I said, I am not so much seeing patients in the medical ward. I'll hardly do around in the medical ward. In fact, if us, we're in a ward, sometimes it's more like surgical, like when they're doing this, or with the oncologists in the clinics. Okay. So PML is progressive multifocal leukoencephalopathy. Now, this one is infection of the oligodendrocytes by a virus, the virus we call polyoma virus or the JC virus. That's Jacob virus. So this virus usually infects the vast majority of normal individuals before the age of puberty, and is asymptomatic at that level. Now, and as I said, it likes the oligodendrocytes. So oligodendrocytes, their function is for myelination. So if it affects them, there'll be no myelination. So risk factors for getting this disease is chronic lymphoproliferative disorders. We did that in hematology, or the myeloproliferative disorders. People who are on immunosuppression therapy, or people who have HIV/AIDS. Okay, those are risk factors for developing this. So as I said earlier, I had seen people with PML, HIV/AIDS with PML those days, but now because of treatment, it's gone down. So what we see is demyelination. We call it actually a multifocal demyelination disease. And we think it's reactivation. Someone got the infection when they were in puberty. So we think it's reactivation of that. Like herpes zoster or those ones. When you have chicken pox, and we think there'll be a reactivation as this. So we think it's that. Onset is weakness, visual loss, ataxia, and dementia. And these people die within 6 months, sort of. Okay. Again, we don't like pronouncing that. I know Julius will say, oh, people got it. So lesions consist of demyelination, patches of demyelination in which the oligodendrocytes show large nuclei with the intranuclear viral inclusions. Then these polyoma viruses are oncogenic also, and the nuclear atypia may be an expression of increased risk of getting gliomas. Gliomas are brain tumors, so you have astrocytomas, they're divided like that. So what we are saying is that this JC, or the polyoma virus, is an oncogenic virus, can cause cancer. So imaging is what they do, which may show ring enhancing lesions, features in the cerebellar matter, white matter for diagnosis. Again, I leave it at that. As I said, I'm mentioning, I already did management generally. So I'm just giving you some that I think are important to mention further. The other one is fungal, as I said, as part of chronic meningitis. I talked about TB, syphilis, and I said fungal. Again, fungal is more in the immunocompromised patients. As a terminal event in more disseminated infection like HIV, we see crypto. Commonest cause of fungal infection in the CNS is Candida albicans, the muco, the aspergillus, the crypto. We see crypto a lot here where we are in our country. Histoplasma, coccidioiditis, and blastomyces. For us, we see Candida and crypto more. So I mentioned those more. Patterns of CNS disease, we'll see chronic meningitis, especially with the crypto, as I mentioned earlier. And many times it will affect the basal leptomeninges and may cause hydrocephalus because of fibrosis on the arachnoid granulations. Can cause vasculitis, more with the aspergillus and the muco, which can cause thrombosis and infarction. I see a lot differently from CNS in that one. Then focal encephalitis with granulomas and abscesses. This may open with crypto again and candida. Again, crypto is like TB. We see a lot of that, crypto meningitis. And you're able to even make a diagnosis in the side lab, and I'll show you how. So it's just sections of the brain showing gelatinous, this is autopsy, of course, material within the subarachnoid space, in between, like here, okay? And then when you look at it under the microscope, you'll see small cysts like this. You take high power with special stain, you will see these ones. You're seeing them like this. Yeah. More in the basal ganglia. So usually what we do, we'll take CSF and you do a test called Indian ink. And this is what we see. You will see the capsule. And you've done microbiome, so mycology, you must have seen this. I remember when we were students, undergraduates, okay, as we were few, so the life was different. So what used to happen, if you have your patient, you've clerked your patient, because we used to clerk from like maybe 6 p.m., 5 p.m., 6 p.m. actually. After visitors go, maybe 6:30 to 7 p.m., you clerk your patient. And because the night lab is still on, and also we had a side lab for students with all the things you need. So when you take the LP, you take to the lab and then the main lab, and then you also take a little and you do in the side lab. During the word round, you actually tell them, actually, we did in Indian ink and we were able to pick cryptococca. And you can start management the next morning. Well, we had a bit of this we used to see. I don't know, I don't see much of this now. Like last week, I'm the one who was covering the hospital. On the bench, we didn't even have Indian ink as such on the desk. We didn't have much of CSF. I don't know, okay, of course, there was a bit of a go slow with the other people, so I didn't much have a lot of that. But yes, this we can be able to see on the side lab or in the, a quick test. You just pour and you're seeing that. So you can read on this on your free time, others that can cause meningitis and encephalitis. And that's the end. The rest will be done now next. So that's what we see. Oh, but there's a question. Wait, I see. This is Kivali, Edel Queen. When you mention management and what happens to those who test positive for both HIV-1, okay. Sorry, I must have mentioned in a way you don't get it. I meant like HIV-1, type 1 is common. Like East Africa, we have HIV type 1. Then you can have HIV type 2, which is more in West Africa. So in Kenya, most of the platforms for testing for HIV are for HIV type 1. So if I'm suspecting the patient has HIV type 2, I take the blood sample and send it to South Africa, not to the patient, not a human. No, it's a blood sample that I'll send to South Africa for them to check whether they have HIV type 2. Because in South Africa, they have bigger labs. And because of a lot of migration, people moving there, your West Africans going there for greener pastures or working. So they're able to have platforms that tests HIV type 2. As here, the labs we have are not able to do type 2. I don't know that for that we was sending to South Africa. I still, if I get a patient and I suspect, I'll send there. The blood sample, not the human. Human we manage. HIV we're able to manage as a country here the same way. It's just testing whether they have. So we use what is more common, which is type 1. Yeah, that's what we see. So it's not like sending the patient there to be managed or whatever. No. We usually send sample. The same way we'll send, like even in cancer, most of the tests will send out, not the patient. So I'll send the block to go and do like a fish. I talked about fish the other time. Fluorescent in situ hybridization. I'll just take the tissue, which is in a block, and send it to, say, Pakistan. Then they test and bring it back like that. It's not the human that you're sending. Yeah, it's not the human that you're sending. It's a sample. Yeah. And for me, the time I had a HIV-2 worry is the ELISA and all that. So I'm sure you guys have done immunological techniques and all that. When you do ELISA, where you're doing enzyme-linked diagnosis in immunology, and you're using mouse, as the antibody. So I remember for us, when we were even being taught, even in MEd and undergrad, those people who were exposed to the mouse, the rats and mouse and all those, some of them already had bites or whatever it is, and so they had already developed antibodies against the mouse. So if that is the monoclonal antibody used to develop the test for ELISA for HIV, so you would have some patients appearing as positive, or those rapid tests that we do, which are maybe indeterminate. So we do PCR to test. So PCR is when you do now that the actual HIV one to check. You look for amplification of the thing. So one of the reasons I remember vividly, there's a patient we had, different Mpisha, Aga Khan, and Nairobi again, and their labs. So when we were doing, because I remember we had a discussion, and they would appear, ELISA will be, these rapids determine, and everything will be positive, ELISA will be positive, but PCR, which is confirmatory, will be negative. So we kept on wondering, why is our HIV-1 negative? Can we try and see whether there's HIV-2 and all that? Yeah, so that's what I meant. And now there are a lot of West Africans also here. But as I said, I'm not sure whether Nani's lab is doing it now, because I remember for us, I'll do a lot of work with the Lancet to send to South Africa. Yeah. So I picked on general, and then I've picked on those that usually interest students, to hear more about. But again, all these are in your books, but it's very wide. So I thought it's just good to summarize, because infections are just too many. It's very wide. So you might get lost along the way when you're doing your infection. So I picked on what I think we see a lot and is more important, etc. Yeah.
Dr. Kaggia, this amoebic meningoencephalitis,
Yes.
is it a case we can find currently in hospitals in Nairobi?
Have I seen a patient with that? No, I haven't. When I write this other one, Otoxo we see, but maybe not really, but it's good.
Okay.
But no, I haven't seen a patient with it. I'll ask my colleague, Dr. Buisa, whether she has seen. She's a lot with infectious. I'll ask her. For me, no,
Yeah,
I
because
haven't.
we are looking for this case.
Mm.
We have an assignment.
Oh,
So
you have an assignment.
We have been able to get it in where we're going for rotation.
Mm-hmm.
So I was just checking if you have any place you may think we can get this case within Nairobi.
Okay.
Or
Tell me
Kiambu.
more. Activate assignments. Go ahead.
Yeah, in clinical pharmacy, infectious disease 1, 2. We are discussing quite a number of infectious diseases. So this is a complication of amoebiasis.
Yes.
Yeah, so we're supposed to go to hospital, identify a case, and find out how it's being managed on the ground, and try to do what you can. If you are in the same shoe, what better can you do based on what now you have studied and what you have learned in class?
okay. I don't know what I will do. I'll share
Yes.
Dr. Buisa's number with Faith.
Yes.
Then the group that has an assignment or that or anything for infections, she's hands-on on infections. She could
Yes.
be the one to help you.
Thank you so much.
Yeah. Sorry, I've not seen a patient with one, so I don't know. But because how she's gone, it's her line, so she would be better placed than I am.
Okay.
Yeah. Let me share right now before I forget. Let me send to Faith that number. Then you guys can talk to her. Just tell her I gave the number. You introduce yourself, she'll be okay with that. We're all usually
That's
very
good.
okay. Mm.
That's fine. Thank you.
And anything else you have, on microbiology, virology, and all that. She's done a lot of work with Kaggia, etc. Itromid. So she's very good with infections and all. If you don't understand what do you call it, pathogenesis and all that, she's a medical doctor, so you can imagine the line. So she's very good at those. So you can easily ask her because she practices that too, more than I do. I've already sent the number because I'll forget. I'm aging. So I've already sent the number to Faith so that wale wanataka more, whatever, you'll call her. Now, of course, I know she's in class, you won't find her. But later on, you'll get her.
Okay.
From 2 p.m., I'm sure you can get her. Anything else? I know it was wide. I know I did summarize my first slides, but I just thought maybe it's good to mention these other ones and show you photos because they're there, the most common. Okay. So you can add on to that during your free time. I'm actually done. I was done earlier, but I wanted to add more things. Sometimes I feel like I'm doing a disservice when I'm not telling you more. So I want you to know, and maybe you get a line that you'll be interested in from here. So we build each other up.
Yes, Dr. Kaggia, on this question,
You guys, you're breaking up.
Yes, I'm asking.
Yes.
This question to describe the CNS findings meningitis. I know when you talk about describe, you can write so many things.
No.
If you just need to look at the kind of the types of infections, maybe look at the bacterial infection, viral infection, and then describe the features. Do you need to do the macro and cross features?
Yeah, not always. This is too open because it's for your notes, revision.
Yeah.
If I'm to give it in an exam, I'll not put it like this. In an exam, I'll tell you actual. So I might say CSF findings for, say, viral vis-a-vis bacterial. CSF. Actually, the best is to say CSF because this is too broad. But remember, I would have 1 or 2 slides for each, viral, bacterial. But change this to read for you as CSF. It becomes easier. Then you do it as a table. I love tables.
Yes.
Yeah, so you can do it as CSF as a table, for example. The other one I would say, morphology, which will be different. For some will have generalized infection. So I'll give you the ones that are easier at your level. This is too broad. Yeah, but because this is reading, your private reading.
Thank you.
Okay, so I don't see anything else, so we can call it a day. I wish you, we'll create time again on 20th for we haven't still done female. I was actually torn in between whether I should do female or but going on with the system, female will still come, don't worry. And it's very exciting, so don't worry. I'll still do that one. I'll not miss my lectures because I think it's very important for us. So thank you very much. Enjoy your afternoon. I hope with time we'll be able to get classes now that we are back on the ground. I think we have a meeting this week with our department and school, so I think I'll also mention that, but I'll talk to your dean also. We see how best these things can be changed. Okay, thank you.